let's talk about evaluation of anxiety. So I'm going to start working through the protocols that you all have. They should have been placed at your seat. One of the things I like to do, I told you about the perceived stress scale. So I like to use validated scales for pretty much every condition that I'm working on with my patients. So anxiety is no exception. I tend to use the PHQ-ADS, the Anxiety Depression Scale. And one of the things that we're doing in our work as a health services company is we're developing more education. And so I want to put a quick plug in the evaluations. We want to hear from you about more content that you want. Like, what are some of the areas that you want to hear more about? I always hear that practitioners want more protocols, at least to start with, especially for people who are relatively new to practice, evidence-based protocols that have the science listed. They want more complex data interpretation from labs. So how do you look at a comprehensive stool analysis and make conclusions? How do you review a note test and make decisions? What do you do with the Dutch test, and how do you track that over time? So if you have additional content areas that you have, please jot them down and put them in the evaluations. The other thing that we're doing is we want to help build your practice and build the tools that you have in your practice. And so we're building an app that contains a lot of these validated questionnaires. So I can tell you, when I first started in practice, I had, like this really ambitious, like 12-page intake form on paper. Does anyone do this? Maybe you still do it. So I had this form, and then I would decide a year later that I had all these other things I wanted to ask about, and so I would add onto the form. So eventually it was like a 25-page dossier that the poor patient had to fill out. And I think we can get so much smarter about collecting those data. And so we have an open source approach that's coming soon in the next couple of years that you can use in your practice to collect this kind of data. And then you have a list of some of the testing that I do for anxiety. They're listed as well in your protocol. Of course, I'm not going to order all of these. When I talk about functional medicine, I think it's important to realize that the present company might be exceptions here. But if we're really going to transform our broken healthcare system, it's probably not going to be with a $25,000 workup at the first visit, right? If we're honest. So we're not going to order all of these tests, but we're going to order some of them, especially the ones that really make a difference in terms of helping our patients with anxiety, helping to understand what the root cause is. Is it magnesium deficiency together with not enough estradiol? Okay, I can work with that. So we can figure that out without a huge workup. Evaluation of depression. I tend to use the PHQ-9, which is actually listed, I think, in chapter 7 of Brain Body Diet. So you might use this in your practice too, or you might use the PHQ-2, which is just a really simple 2 questions that have been validated to show as a screening test that it's really helpful for depression, and then you can move on to the PHQ-9. Yes, so depression is chapter 7, page 253, and so you have the PHQ-9 listed on page 255. And then for the cases that I have in this chapter and all the chapters, you can also see their labs in the notes. And you'll notice there's a lot of overlap between the workup that I do for anxiety and the workup that I do for depression. And I think that relates to phenotype. I think some people have this genomic risk where you put a similar input in, and they either go down the depression path or the anxiety path, or they have a combination of the two. And some of those genes are listed. I know we got into a gene discussion. So here's some of the genes that have been proven to be important in terms of risk of depression. Hopefully I have, oh, I see I do not have that on the anxiety slide. I'll have to fix that. The genes are listed in the book. So how do we reduce inflammation in anxiety and depression? I think there's 5 different strategies. We're only going to have time to go through a few of them. Food, psychobiotics. That includes prebiotics, probiotics, occasionally the use of antibiotics. How many of you prescribe antibiotics for SIBO? Some of you. Okay. One of you. Okay. Herbal therapies, behavior pharmaceuticals, that's kind of the new name for behavior changes, changing what your patients do behavior-wise, like exercise, sleep, et cetera. And then hormone modulation and therapy. So let's talk about food. So we know there's certain foods that are associated with decreased anxiety. This has actually been really well proven in the literature. Magnesium-rich foods, B vitamin-rich foods, healthy fats, probiotics, and bone broth. We know that in susceptible individuals, that caffeine, sugar, refined carbohydrates, processed foods, packaged foods, I'd put glyphosate in here too, alcohol, maybe even lectins, and conventional cow's milk is associated with higher rates of anxiety. I don't think of these as on-off switches. I think it depends, again, on the genes, gene-environment interaction. I'll give you a quick example. Caffeine. How many of you know that you're fast metabolizers of caffeine? Oh, okay, some of you. So the rest of you know that you're slow metabolizers? Or you don't know? Okay. So what we know, you may have observed this, that if you look at all the literature that we have on coffee, about half the studies show that it's a great idea, that it's associated with increased longevity. There's all these benefits associated with it. And then half the studies show that there's adverse effects associated with drinking coffee. And the problem is a lot of the literature did not divide patients into either slow or fast metabolism of caffeine. So we know that the fast metabolizers tend to process caffeine 3 times faster than the slow metabolizers. The fast metabolizers are about 49% of the US population. They're the ones who drink coffee. They get incredibly focused, incredibly productive. They could even have a couple of shots of espresso after dinner and fall asleep that night. So those are the fast metabolizers. And then there's people like me who are the slow metabolizers. I drink a cup of coffee and I am a jittery mess the whole rest of the day. Now, there might be some other things in that coffee. There could be some other toxins besides the effect of caffeine as it manifests in my body, but I get none of the benefits. I get all of the adverse effects. I'm much higher. My rate of sudden cardiac death is higher after having a cup of coffee. I probably need a higher dose than that, but basically, I have to keep my caffeine intake less than 200 milligrams a day, and I perform much better if I drink it as green tea before 7 a.m. So I figured out what my parameters are, but that's an example of the gene-environment interaction. That's a really simplified example, but I think it shows up in terms of how we respond to food. The depression literature, I would say, is even more robust because we know that traditional diets especially are associated with lower rates of depression. And some of those traditional diets include the Mediterranean diet, the Norwegian diet, which is a thing, includes a lot of salmon, the Icelandic diet, the Japanese diet. We know that these diets are really rich in B vitamins and dark green leafy vegetables, rainbow-colored vegetables. You know, the goal is to get 5 to 7 colors of the rainbow every day in order to prevent micronutrient depletion. And prebiotic foods and probiotic foods. We know that sugar, processed food, grains, alcohol, and caffeine are associated with higher rates of depression. So let's talk about psychobiotics. We only have a few minutes left before we're going to go on to the Q&A. We've got 5 minutes. So I want to hit a few highlights here because we've talked about some of these already. Since we were talking about human breast milk and feeding the microbiome, especially when an infant is first born, feeding the beneficial microbes with human milk oligosaccharides, and how you can now take that as a supplement. So human milk oligosaccharides, this was actually there's this conventional wisdom that if you have a patient with small intestinal bacterial overgrowth, that you should not use prebiotics at all because it's going to increase symptoms. It's going to cause bloating. It's going to cause a fraternity party that you do not want to create in the gut. But I would say my experience is that you can actually work with human milk oligosaccharides in your patients with SIBO. So you have to experiment a little bit with that. I don't know if there's any experience in the room, but it's one of the things that I found incredibly beneficial for transforming my own microbiome. So human milk oligosaccharides, I think another area that's really interesting to keep your eyes on is resistant starch. So you'll be hearing more about that in terms of modulation of the microbiome going forward. This is one of those slides that just makes people go to sleep, so I'm going to skip on here to some other points. Let's see if we have something really fun here. Okay, so I like this slide a lot because it goes through the different strains of probiotics and proven outcomes associated with them. So an example here is at the top. This particular strain is associated with improving symptoms of bloating in patients with functional bowel disorders like irritable bowel syndrome. So you have this slide with some of the strains that have been the most proven. We're definitely heading in that direction of being more strain specific. One of the things, when I was talking about how we're in the early days of understanding microbiome manipulation, when I was going through my training, our thoughts about probiotics was mostly like volume. Like, okay, you give a patient a course of antibiotics, and then, right when they finish, you give them replacement antibiotics, and here's how much you should take, and it's a lot, and see if they can tolerate it. And what we're learning is that volume is not the only factor, and it's probably not the right factor. We need to get smarter about strains. I want to make one other point about inflammation. I've talked about the gut-brain axis and microbiome manipulation, but I think another essential point here, especially for patients who have deficits of inflammation resolution, that there are other phytonutrients that modulate the inflammatory cascade. So I'm not going to say a lot about this, but here's some of the ones that I know you know about. Things like curcumin, boswellic acid, ginger. These are involved in TNF-alpha, NK, kappa B, a number of different downstream regulators of inflammation. And so it's important that this is part of the protocols that we develop. So for anxiety, I mentioned that you have 90 randomized trials supporting the natural ingredients that are listed on your protocol. And I'm just going to highlight a few of these. There's some foundational ones that you all know about, omega-3 fatty acids. I'm not going to have time to go through all of these, but we know, for instance, that there was an article published in JAMA last year showing that people who have anxiety, men and women, tend to be very low in omega-3s. And people who take 2 grams a day of omega-3s have much lower rates of anxiety. 2 grams a day, that's not much. Now, if you go to the Alzheimer's Prevention Clinic in New York with Richard Isaacson, he's going to tell you to take 4 grams a day of omega-3s, preferably as fish oil, because that's the most proven. So we have a list of things that we use kind of depending on what we find with genomics and also with biomarker testing. And I'll make a quick point about melatonin. I used to be kind of careful about melatonin in my patients, and then I read some new data showing that melatonin actually improves the integrity of the blood-brain barrier. The citation is in the book. And once I read that, I realized, oh, maybe there's some other reasons to prescribe melatonin besides just helping our patients with sleep. We know vitamin D, inositol help with anxiety. And then I just wanted to highlight a couple of the things that I mentioned. Lavender, used a ton in Germany, our friends the Germans. So they're the ones who did the randomized trials with oral lavender as a soft gel for patients with anxiety. And here you'll notice that rhodiola is on both the anxiety and the depression slide. And then we also have Siberian rhubarb listed here. So I don't try all those things at once, obviously. I go through a stepwise approach, and it kind of is personalized to the individual. So protocol listed here for depression, similar to anxiety. You notice that rhodiola showed up again, as well as St. John's wort, N-acetylcysteine, in part because it's one of the best antioxidants that we have, and it increases glutathione, and it helps with the downstream inflammatory issues that we see with anxiety and depression. So the depression protocol only had 73 randomized trials. So this is the patient that I mentioned earlier. I think we're going to stop here and go to questions. I'm just going to recap for you that she first came to see me, Karen, when she was 45 years young. She had premenstrual anxiety. She had tried pharmaceuticals before. She felt like they just numbed her out, antidepressants mostly, also benzodiazepines, but didn't solve any of her problems. So I put her on an elimination diet and lavender oil, and that worked for her really well, 80 milligrams twice a day for a few years. And then when she was about 48, we ended up taking away the lavender and adding Siberian rhubarb, and it made such a difference for her. So some of the other things that are proven for premenstrual anxiety are listed here: vitamin B6, magnesium, and also vitamin D.